So, artificial disc technology, as Dr. Teen pointed out, was designed to replace degenerated or injured discs with a prosthesis that would allow some motion or maintain normal motion at the operated segment. When they first came out, like I said, they were thought to be the best thing since sliced bread. I think Johnson & Johnson purchased the Charité artificial disc for $300 million, and when it was FDA approved, I believe that's the correct number. And then they were sadly disappointed at the actual numbers of discs that were utilized. And I admit that part of it was related to insurance company denials, but it was first anticipated that 25% of fusions would go to artificial discs, and that just wasn't the case. You know, even though the goals of this new technology was to provide improved outcomes, enhance safety, lower cost, minimize adjacent level degeneration, a lot of this just didn't pan out. Now, the goals of surgery when you do a fusion and when you do an artificial disc are different. Some of them are the same. Restoring disc space height is the same. You want to do that with either procedure. You want to reestablish the normal lordotic angle, like we talked about in the sagittal alignment talk, with both of them. Obviously, with a fusion, you are not reducing or preventing adjacent level degeneration, or you are not preserving mobility at the level. What you are doing is stabilizing that segment. So it's a circumferential operation where you're adjusting the whole spine, the facet joints, the disc, everything, whereas the artificial disc is not doing that. You're going for purely discogenic pain. So the ideal candidate for artificial discs is somebody with pure discogenic pain with no significant facet joint changes, no previous fusion or other operations involving the facet joints, no canal stenosis because you're not doing any decompression, no more than 3 millimeters of spondylolisthesis maximum. You can't have any significant compression of the nerves because you virtually cannot do any decompression. You're coming in from the front, not the back. And restoration of normal motion may potentially increase radicular pain or even initiate it that's not previously there, because you can take a degenerated disc and you can give it normal, you can put motion into that wasn't there, and you can create radiculopathy. And I've seen that a number of times. And if there's a posteriorly herniated disc or lateral recess stenosis, then you would have to do a separate operation to address that. So patients in general with significantly collapsed disc spaces are not good candidates for artificial discs. So Bertagnoli, I think that's how you say his name, defined the ideal candidate for an artificial disc as a single level disease, greater than 4 millimeters of retained disc space height, no evidence of osteoarthritis at the facet joints, intact posterior elements. In other words, young patient, normal spine, no neurologic deficits, and disease defined by MRI and discography at the single level. Basically, he looked at 252 patients that needed surgery, and one of them met all those criteria. One. So 0.0 or 0.4%. Okay, so in doing biomechanical comparisons as well, you do have an accelerated degeneration of the facet joints at the adjacent levels. I admit that with the fusion. No adjacent level instability. If the artificial disc, you can't have any adjacent level instability at the artificial disc level. So what was found, so actually, this is a little, so what they did was they looked at biomechanical differences at the surgical level, okay? And what they found was by removing the annulus and the disc and placing that artificial disc, you created instability at that level, okay? And then because you changed the biomechanics at that level, you actually did increase the stress on the adjacent level, the facet joints, and potentially accelerated degeneration, which is similar to the posterior interbody fusion. So, what did we do? We just eliminated that 0.4% ideal candidate for the artificial disc. So, obviously, as Dr. Patine pointed out, one of the primary goals of arthroplasty, which he repeatedly stated in all these retrospective articles, that you want to prevent or reduce adjacent level degeneration. Well, looking at the clinical studies, from European Spine Journal, 36 of 75 patients that had artificial discs placed, 48% showed adjacent level degeneration. No statistical difference in the development of adjacent level degeneration in the fusion versus artificial disc patients in these other 3 papers noted here. What's the cause? Okay, as I mentioned, the consequences of stresses on the adjacent levels of the spine generated from unphysiologic motion at the device level accelerated the adjacent level degeneration. So, you know, the problem is you have to figure out what's the difference between the natural history. Obviously, these people who are having surgery for degenerative conditions have a predisposition to adjacent level disease already, because at that level they will probably develop anyway. A certain percentage of them will. So the question is, and that's the million-dollar question. These are MR images from a patient who had an L5-S1 artificial disc placed, a charité, 1 year earlier, who then, 1 year later, L4 radiculopathy. This is the axial image through that, showing a far lateral herniated disc causing, guess what, radiculopathy from adjacent level degeneration. Okay, so some of the biomechanical characteristics, motion restoration. The other big problem with these discs, you know, if you really did maintain normal motion at all these levels that you place these artificial discs at, it would be great. Unfortunately, we don't. So, in the actual FDA study for the artificial discs, there were 70 patients, or 39%, basically approximately 40%, had 5 degrees or less motion at 24 months, which, by definition, is fusion. So, looking at other papers, Poussière, out of, how many patients did he have? 12 of the patients in that study, 23% had segmental fusion, 32 had spontaneous ankylosis, and only 9, 17%, similar to the charité study, had continued normal motion at that level. So heterotopic ossification has been reported to be as high as 60, 76% at 1 and 3 year follow-ups in multiple other studies. What are the causes? Maybe it's because surgeons decorticate too much of the vertebral end plates. Maybe it's the natural progression of disease. But this is a perfect example here. I mean, this is a better fusion than I get doing a T-lift. Okay, two level artificial disc, solid fusion. So, what about some of the other biomechanical characteristics? Metal-on-metal devices were compared with polyethylene core and paper. Neither one of them had any significant effective shock absorption. Okay, what about wear debris? The potential significance of wear debris on the end plates and adjacent neurological elements still remains unclear. Okay, in multiple experimental settings, they lost discs, charité discs lost significant height over approximately 10 years follow-up, and significant wear debris in multiple papers. This is an example here of a patient who had L4-5 and L5-S1 artificial discs removed. This is 6.5 years after they were placed. Whoop. After they were placed. And it shows a fracture of the metal wire, damage of the polyethylene core, and significant wear debris after 6.5 years. So, clinical results in the Poussière paper were actually better in the patients with spontaneous fusion. Okay, so the patients that had, he took all these patients that had artificial discs replaced and were in the ones that had spontaneous fusion at the level of the artificial disc placement. How could that be, right? The goal is to maintain normal motion, right? Well, like I said, you know, when you place an artificial disc, you're changing the biomechanical characteristics and potentially overloading the facet joints and changing the angle of rotation. So what he found was when you get a fusion, spontaneous fusion, which, as we noted, occurs in up to 60–70% of patients over the long term in these artificial disc patients, when you obtain a fusion, these patients actually do better. So after implantation of artificial discs, the loads in the facet joints can increase approximately, are thought to increase approximately 2.5 times. The facet joints are additionally overloaded as a consequence of removal of the anterior longitudinal ligament, so part of the procedure, and the annulus, and producing axial rotational instability and progressive degeneration of the facet joints, not to mention the complete lack of shock absorption. So, how does this impact clinical outcomes? Facet degeneration in 25 of 75 patients in this paper, facet joint degeneration was visible on CT scans. And instability is created after, like I noted, the anterior longitudinal ligament and the annulus, and replaced with an unconstrained prosthesis that can contribute to the instability in the facet joints, especially in extension and lateral rotation. So the joints basically become the only restrictor of the axial rotation and will degenerate in an accelerated fashion over time. This is a 49-year-old man who underwent a 2-level total disc replacement. After 1 year, he felt his back pain was substantially worse. X-rays, you can clearly see, compared to these other levels, the facet joints are severely degenerated, as noted on the CT scan. No doubt about it. So, clinical trials. You know, Dr. Patine showed all those studies, which is, you know, really very nice and impressive. But when you really get down to the meat and potatoes of that data, which, you know, one thing that putting together this talk did was really made me dig into this data, and it was an eye-opener because it turns out all those 3 discs that Dr. Patine talked about, the Maverick, the Kineflex, the Charité, not a single one of them is currently FDA approved. The Charité was, and it was pulled off the market for various reasons I won't go into, and the Maverick and the Kineflex have other issues. The other problem is those studies were inherently flawed. The Charité was compared to a BAK fusion. Now, when was the last time anybody saw a BAK fusion performed? Maybe 5, 8, 10 years ago? It's not used. Even when the study was ongoing, it wasn't being used because these were, I don't know if you all remember the cage rage in the 90s, but these BAKs came out and they were just like Arnold Schwarzenegger and artificial discs, thought to be the best thing since sliced bread. And everybody and their brothers started slamming these things in, and then they figured out, wow, these things don't actually work so well. So they stopped using them. And nobody that I know of anyway uses them anymore, and that's what the Charité was compared to, an obsolete fusion method that nobody uses. Similarly, the Pro Disc, not quite as bad, but similarly, was compared to AP fusion. Okay, most surgeons don't perform AP fusions for simple degenerative joint disease. It's just an enormously invasive, destructive procedure, and there's no reason for it. Nobody in our group, anyway, 5 surgeons, performs these routinely at all. So again, you know, they're taking procedures that we don't use, and then they're comparing them. Okay, so the other problem with the trials is they were not designed to show superiority of the devices, which they should have been. If that's what they want to say, that's what Dr. Patine wants to say, that these devices are superior, then you have to design the trial to say, a priori, we're going to prove that these devices are better. Instead, what they did was they designed them to show non-inferiority. So they took crappy fusion procedures that nobody uses, and then they said, okay, well, these devices are no worse than that. Okay? Then, retrospectively, they go back and pull data and say, oh, well, these things are actually better, turned out to be better in the artificial disc cases than, than the fusions. Well, you can't do that. Any statistician alive will tell you that's completely invalid. So it's just like the steroid stuff. You can't go back in a study and start picking out data and try to find something with a p-value less than 0.05, because you will find something. There's too many variables. It just invalidates the whole conclusion. So there's no basis for the claims that these devices result in improved outcomes. And what did the devices actually show? The one thing they did show, I will admit, that the artificial disc patients had shorter recuperation periods following surgeries than the never used, obsolete fusion procedures that they were compared to. So, given all that, you can see who's in charge of the corporate PR and the smoke and mirrors departments. It's just not true. So, motion is not measured as an endpoint of success. The first 26 patients in the Charité patient were completely thrown out because I think they had too many complications. I was actually part of that study. I was at Cedars. Success was defined as more than 25% improvement in ODI at 24 months, no device failure, no major complication, no neurologic deterioration. Safety data, what data did they show? Unfortunately, the adverse event definition was not provided, but the overall complication rate was 76% and 77% in the artificial disc and fusion patients combined. Remember, obsolete, never used fusion techniques. The rate of adverse events was even higher in the 26% patients that were initially done, that they called training patients, basically. So, artificial disc replacement compared to BA cages, outdated technology that is not currently used because of high failure rates and better alternatives. Patients with collapsed disc bases were excluded. BAK cages are not good for that anyway. Clinical outcomes, success was achieved in 57% of artificial disc replacement patients and 46% of fusion patients. The results in the fusion group were very poor compared to similar fusion techniques that we actually use today. 72% of arthroplasty patients were still using narcotic pain medications at 2 years. Okay, so what does that tell you? 3/4 of the patients with disc replacements were still on narcotics 2 years after they had surgery. I mean, that's a bomb. Including 64% of those judged to have achieved clinical success. Even worse, okay, return to work rates were less than 10% in the investigational and control groups. And the mean age of these patients was 40 years. Less than 10% went back to work. I mean, that's horrendous. So the other problems with artificial disc replacement requires a perfect procedure. So you can go in and do a fusion, and you put the screws in a little bit crooked, you put the implant, the interbody spacer in a little bit crooked, it's no big deal. The patient fuses and they have a good result. If you do that with an artificial disc, it can be a disaster. You need a perfectly straight anterior approach. You need to have the disc perfectly positioned. And even in the expert surgeon FDA ID Charité study, they implanted 17% of the devices in suboptimal locations. So what they did, though, is they said they divided the device and approach-related complications. They separated them out, and they shifted the blame from the disc to the surgeon. And they said, well, not a problem with the disc, it's a problem with the surgical. Well, if 20% of the best surgeons in the world are placing them wrong, then you can see it'll be a lot worse once they get out to the normal community. There's multiple different design laws that I won't go into in great detail, especially since the Charité is not even on the market anymore, but they don't really match the vertebral end plates very well. The fixation between the metal and bone is inadequate. The core, polyethylene core is problematic. Pro disc, similarly, the spacer is non-slinked, has a dome shape that articulates with the metal cup, and the center of rotation is placed anteriorly such that it significantly loads the facets and causes pain and more problems. So, what about complications? Of course, patients have complications with undergoing fusions as well, but I would say confidently not to the same extent as the artificial discs, okay? Looking at these complications, I don't know if you remember that patient, Dr. Peen, that I took care of after you put that disc in?
That is a lot.
Well, then you may remember this one.
That is another
This is a patient with new onset low back pain approximately 4 months after implantation of the pro disc, and shows the anterior migration of the superior end plate over the inferior end plate. And it was thought to be a result of the separation from the polyethylene inlay from the inferior end plate. Okay, so there's a polyethylene core here that clicks into this end plate, the metal end plate here, and it was thought that popped out and dislocated basically. You know, there's worse than just simple device migrations. I don't know if you can see this, but here's the sacrum and here's the rest of the sacrum where it's fractured off and pushed forward, and obviously it's completely dislocated. Here's a case where the device subsided literally all the way into this is the vertebral body, and the device is essentially inside that. So, you know, this one is really no better. There's worse. You know, this is it demonstrates anterior migration and extrusion of both the superior and inferior end plates, as well as the metal ring. I would consider that a bad outcome. Also shown here is, again, if you place these discs even slightly to one side or the other, unlike a fusion, you have a high risk of failure, subsidence, dislocation. This is a patient that somebody in Loveland, I can't remember the name, tried to salvage after they placed two-level artificial disc, which obviously is over to the side a little bit again, and they developed scoliosis after surgery, so they tried to put a dynamic motion stabilization device in here to salvage the procedure, and needless to say, it didn't work. So you can see multiple examples of just disastrous consequences, one after the other. This one's again placed to one side just slightly. It's very difficult to get these things in the perfect position, and some subsidence into the end plate. You know, sometimes we see vertebral body split fractures right down the middle. Okay, that's also considered not good either. And here's bilateral pedicle fractures from another device that has subsided and dislocated. Are you guys getting the picture here? Yeah.
Yeah.
Precipitating traumatic event.
I'm sorry, I can't hear you. Hold on. Let her give you that.
Raise your arm.
I'll just leave this picture up so you can try to figure out what's going on there for a little while.
Was there any precipitating traumatic event that resulted in these failures?
Some of them, yes, but a lot of them, patients get out of bed and stretch, and they feel a pop, and that's it. So this is a Charité implant. Shortly following the surgery, I'll admit that they could have placed this one a little bit more posteriorly, but come on, here's the vertebral body here. You know, it wasn't bad enough to cause that. So, I mean, this is just all of the above, you know, fracture, dislocation, everything. Failure of posterior elements. Here's a patient who had a 5-level artificial disc replacement. This would probably not be consistent with the United States FDA indications for use, and would probably represent an example of irrational exuberance So what about all these cases? You know, what do you do with these cases revisions? You know, that's another problem. You know, if you do a fusion and you get a pseudoarthrosis, you go back and you redo the fusion. If you get these total disasters with these artificial discs, obviously if it pops out and it lacerates the inferior vena cava or the iliac artery, then you don't need to worry about it because the patient's dead, so it's not your problem. But in those cases where the patient actually survives, then you got to go back in there and fix that, and it's horrendously difficult sometimes. You know, there's a ton of controversy in how do we deal with these things. Revision, do we do revision surgery to remove the implant on these patients, which is potentially life-threatening, or do we try to salvage it by just throwing in some screws posteriorly and doing a fusion? You know, we don't know how long these things will last either. You know, the average age of these being put in is 40 to 45 years because patients can't have any facet degeneration, significant disc space collapse, spinal stenosis, lateral recess impingement, hernia. Can't have any of that. So it's basically you have to have somebody with a normal spine who wants an operation to put one of these things in. So they're going to live a long time, all right? And when these things wear out, like all the ones that I showed you, you're going to have to do something about it. Reported reoperation rates of 34%, and we haven't even been putting these in for very long. So if you look at the anatomy, you know, there's some big vessels right in front of the spine here, down there. You know, that presents a problem. Where, like I said, if you're going back in to do a fusion or redo fusion, you go by, you go to the side a little bit. But you can't do that with an artificial disc. You got to go straight in. Okay, so it's much more difficult. So what are the clinical outcomes after surgery? Again, there's no consensus as to how to treat a failed implant. Okay, do we do the posterior fusion without disc removal? Do we do anterior posterior fusion with the disc removal? 75 patients were enrolled in a study that had persistent leg pain and back pain after insertion of an artificial disc. They were enrolled in the study. They underwent removal. They either underwent removal of the disc or with a fusion, or a simple posterior fusion with leaving the disc in place. And the patients that had the disc removed had slightly better results. So does that mean we subject them to a potentially life-threatening procedure to get those discs out and do a circumferential fusion? I don't know. It's a tough question.